Fiona, welcome. This is the third in a three programme series of iViews coming through courtesy of iNews, which rhymes quite nicely. We're covering a number of aspects in terms of retinal conditions, specifically around the macula and macular degeneration, but more broadly, the different perspectives and the different views of folk involved in care and those at the receiving end. So we've had conversations with ophthalmologists, with our patient representative, Malcolm, who you know well.
Yep.
And so the purpose of today is to get a bird's eye view of what goes on in the high street, and arguably the most difficult challenge in seeing healthy people, less than healthy people, in large numbers in a very short period of time, and then trying to balance both the business and clinical curiosity and professional satisfaction. So that is the backdrop, Fiona. But first of all, hopefully there'll be more than just the one listener. Tell us a little bit about yourself, Fiona.
So I am an ophthalmologist. No, I'm not. Sorry.
Oh, you could be an ophthalmologist. As a Freudian slip.
Yeah.
I mean, that is an interesting question. There's ophthalmology a temptation? Medicine just generally? Never.
No.
Wow. So how did you get into optometry?
I actually, probably when I was about 13 or 14, when in Scotland you start sort of picking your subjects in school and start thinking about careers. And the boy who sat next to me in class said he wanted to be a dentist, and I thought, I can't think of anything worse than being a dentist. I absolutely hate going to the dentist, but I quite like going to the optician.
Okay.
So I did some work experience and really enjoyed it.
Yeah.
And so that kind of led me down that path. So, I mean, I think there's sometimes a bit of a misconception that people fall back on some of the more kind of allied health professionals because they didn't get into medicine, which is not the case. There are some people who go down that route, but for many it's just that's what we're motivated to do. I enjoy the kind of primary care aspect of it.
That's fascinating. So it never was mentioned at my careers advisory chat at school.
Yeah.
I think my mum told the careers advisor there are only three options. And I think good for you. And you went to Glasgow Caledonian University.
Yes, I did.
Okay. And enjoy that experience? Did it make you regret not becoming a dentist or an ophthalmologist?
No, Caledonian's a great place to study. In fact, I liked it so much that I now go back there and supervise the students in the clinic. It's a really nice mix of sort of the practical and the theoretical, which it is optometry and actually all healthcare professions are kind of strange in that you do have to have that kind of book smart, and particularly with optometry, you have to have a knowledge of physics and this sort of thing, but you also have to be quite personable and be able to talk to patients all day, and those things. It's not a overly common mix to have, excel in both of those aspects, but certainly all the optometrists I know seem to do well, and that having that kind of knowledgeable background, but also the knowledge is nothing without being able to communicate it to your patients.
Absolutely, it's a real key skill, and not everybody has it. But you have it in droves. I've worked with you for a couple of years, and it's clear that being a natural communicator is one of your many talents. So I don't think it'd be rude to my previous guests, ophthalmologists, and Malcolm, who I think by background was a physicist, but certainly is a very good communicator. It wouldn't be rude to them to say that you're by far, in a way, the youngest guest we've had on this series of three iViews podcasts. You told me you were a zillennial, which was news to me. So that sits between
Millennial and Gen
and
Z.
the Gen Z.
Kind of
Okay.
straddle the two.
Yeah. And so as an optometry zillennial,
Yeah.
you have a unique perspective, because when I'm a baby boomer, which is back in the mists of time when babies were booming, I suppose, which is how we got our name. The interaction between optometry and ophthalmology was a little bit fraught, and traditionally there wasn't as much joint working as there is now. Do you think that's because it's been driven by zillennials, and the zillennials see this as being an important thing to evolve, progress, and just develop further?
I think communication between the specialties, it definitely is improving. Part of that is that technology has improved. We have electronic referrals, which means that, we can send imaging and, clinical records across instantaneously and have these triaged, which obviously helps. Certainly, I think COVID moved it on a lot as well. There's a lot more cross management of patients across, the hospital, primary care, and the GPs as well. And, these things like virtual clinics and things like that, a lot of that was in the works anyway, but it certainly accelerated by the pandemic. But yeah, the demographics of optometry are changing. You look at the Association of Optometrists workforce analysis previously. It was a very male-dominated profession. There's sort of the maybe stereotypical view of any kind of primary care health provider is sort of an old white man with white hair and a white coat. And certainly that's not optometry today. There are still those who fit that description and are excellent practitioners and a vital part of the optometry community, but it's certainly becoming more female, younger, and more ethnically diverse as well.
Yeah, terrific to hear. And so that was your very pithy description of a standard optometrist, or as they used to be, or maybe still are currently. And what was the perception of the ophthalmologist from the optometric point of view? How would you have characterised us, inverted commas?
I certainly don't want to put words in the mouth of the whole profession, but yeah, I guess maybe there's maybe a perception. Obviously, it takes a lot longer to study and do all the training and qualify to be an ophthalmologist, and you're very highly specialised in the area in which you practice, and so certainly there's a looking up to ophthalmology, which does of course still happen because you're our respected colleagues, but I think it is more a view of colleagues in that sort of collegiate way of working now than maybe it has been in the past. And some of that is helped with the eye care system in Scotland. We're able to manage and co-manage patients in the community so much more than previously. So rather than having to sort of refer to the hospital in many instances, a lot of the time we're able to keep the patient in the community, whether that is managing them as a standalone if you feel confident doing so and you have the appropriate training, or whether that's in co-management with the hospital, but avoiding kind of unnecessary travel and appointments for patients.
Yeah. No, I think that evolution, I've certainly seen it transform in my working lifetime, and it's delightful to see, and it's been a long time coming. But in terms of your desire not to be a medic, sitting next to that lad who wanted to... Is he a dentist now, incidentally?
I have no idea.
What was his name? Surely you remember his
name. It was Ryan something.
Ryan, if you're listening, get in touch. We want to know which dental practice you're working at. Could be a DJ in Ibiza now, you never know. So having decided not to become a medic, you're doing a lot of the stuff that medics do in terms of healthcare prevention of problems and progressive disease. And you're seeing a whole load of people who you're sharing the care with hospital departments. So in that sense, you have evolved into something that you didn't really want to become, at least as part of your job. So how does that sit with you?
Well, for me, and I think the way that the profession is going, previously it was quite refraction based. Obviously, refraction is a very important part of our job, but the way technology is going, I think at some point probably refraction in non-complex patients may be taken over by some form of technology or machine, and so it is really important for the profession to continue to expand our scope into that healthcare region, and make sure that we are providing care as we should be in that kind of primary care role.
Because I think it's been a gap that hasn't really been filled in previous times. Certainly preventing disease is a hell of a lot better than trying to close the door after the horse has bolted. So that
exactly,
I think carving out a niche is very much needed pretty across the board. So just extending that a little bit further and bearing in mind that you have taken on at least part of the mantle of the medic in that sense, or the public health eye care professional, where do you see research sitting in that? Because you probably were exposed to some degree of research at the Glasgow Caledonian University. You probably had to do some research after that, and I know that you're doing a master's.
I've just finished it. I submitted my thesis 2 weeks ago.
Fantastic. What was the title of your thesis?
A distribution of optometry practices across urban rural locations in Scotland, implications for equity.
Oh, great. Because you were going to do it on macular degeneration.
Yes.
But then there were too many hurdles.
Yes, some bureaucracy got in the way of doing that initial project in the kind of time scale of the masters. So switched. I work in rural practices quite a lot as a locum, and there are some very specific challenges that are faced in that environment. And so I felt being able to bring that perspective into what's known about optometry access was quite important, because it's not as well studied as maybe some other issues in equity of access to eye care at the moment.
Absolutely, you have to send me a copy of the thesis. Anyway, well done on doing that. So you've certainly got the itch of a research question that you want to scratch in the sense of both your masters and also some of the work you're doing. You mentioned, though, before we talk about that, you work in locum as a locum. So why are you working as a locum? Is it better money? Is it more flexibility? You just don't fancy being pinned down in a high street chain?
So I've worked as what we call a resident optometrist. So that would be an employed optometrist for chains in the past. I worked for Specsavers for many years. I've worked for independent practices. I found for me locuming helped me give a kind of balance between the different things that I wanted to do. So I enjoy being in practice, but I also enjoy the sort of teaching and clinical supervision. I do it at Caledonian University, and obviously in the last couple of years joined the University of Edinburgh as a research optometrist, and so it allows that kind of flexibility to do all these different things that I enjoy doing.
Yeah, it's brilliant because you're making the most of every opportunity, and I think that's laudable. So as far as you can generalise, do you think you're typical of the zillennial optometrist? Because not everybody either sees research as being vital or important or driving service quality. Do you think you're an outlier, or do you think you typify your generation?
So I think certainly from the friends and colleagues that I went to university with, a lot of us are looking for something a little bit beyond just sitting in the test room saying 1 or 2 all day, which is very, very important. But, you can see it in the number of optometrists taking on additional qualifications. They're doing their independent prescribing or master's degrees or whatever it may be. And there certainly is a bit more flexibility in people maybe wanting to work in the hospital part-time and work in community or high street practice part-time, or, becoming an assessor for the College of Optometrists. So there's definitely, people are looking for that something a bit beyond just the kind of everyday routine. And I think optometry is a great profession for that. There are so many things that you can do to sort of expand the scope of what you're doing, maybe more so than you might think with such a highly specialised profession.
Yeah. Oh, no, that is great to hear. And of course, you could say that being a locum means that when you prescribe specs and the customer isn't happy, you're not going to be there next time around. I mean, I do but jest, but one of the bugbears that I think every ophthalmologist sitting in hospital have is that patients, understandably, and I'd probably be the same, take along numerous pairs of spectacles, which are then emptied out onto the desk. And folk do say, I can't see with these, and I spend a fortune on them. So I was going to ask you, I suppose in a slightly teasing way, what do we do about that? Do we just tell individuals like that to, go and see your optometrist, locum or not? So
ultimately, if the spectacles aren't working, then the person should be visiting their optical practice. I tend to work in the same places all the time as a locum, so I usually do get to follow up with my patients.
Does that happen a lot though?
So if you're a locum, you still have responsibility to look after your patient and follow up. So even if you did one day in a practice, if you're, let's say, referring someone, you need to be following up on making sure that person's been looked after.
Okay. So what I've been saying is go and get a refund. That won't be an issue. Is that right?
So definitely, if there's something that's not feeling quite right with the glasses, then going back to where they were supplied, they should be able to sort it out, whether that is, sometimes it's as simple as, maybe the varifocals aren't sitting quite right on the face, they need a simple adjustment. Sometimes it's a case of rechecking the prescription. It is a subjective measure, and sometimes adjustments need to be made from that side of things. Or sometimes it's just that maybe there wasn't the correct communication there, and particularly with people who have pathology or a certain eye disease, it is about managing the expectations of what level of vision is achievable, and making sure that we're getting the best vision that we can do, but sometimes understanding that there's a limit to that. And I would never want a patient to go home and think that they'd sort of been fleeced into buying a pair of glasses that don't work. If that's the case, then often it's an indicator that the communication is broken down at some point in that patient journey.
Sure. Well, I think that's very well put. I'll remember that for next time and not claim that they can get a refund instantly. So it kind of highlights, I suppose, the expectations of the general public, most of whom I'd imagine, although I don't know, attending your practice will be relatively healthy and will have an optical problem that can be corrected with spectacles. But some of them won't be, which is absolutely the reverse in the hospital scenario, where if somebody comes in and there's absolutely nothing wrong, that's very much a rarity these days, because they get pre-screened and they get referred, as you described, and the referral pathways are now very effective. So that is a difficult thing to balance. One person might have glaucoma coming in with advanced visual field loss, and the next person will be saying, I don't like my Dame Edna Everage spectacle frames. What are you going to do about that? I mean, that is a tough gig, isn't it?
Yeah, so I think it's absolutely right that you shouldn't be getting perfectly normal, healthy patients in the hospital. That's what primary care is for, is to screen these patients out and make sure we're making efficient use of the health service.
Yeah.
But yeah, that's certainly essentially the biggest challenge of any primary care practitioner, is that most of your patients are going to be relatively healthy, relatively normal findings on your tests, and you have to stay alert to those very subtle early signs of disease so that you can pick it up at the early stage and not just get into the routine of doing the same thing and making sure that these things are being detected. And certainly with increasing use of technology and all the different pieces of equipment and things that we have available to us now, that certainly makes things easier in that respect, and we are able to detect things at these kind of earlier stages.
Yeah, because having said that, most people are generally healthy given enough time and the vagaries and the fortunes and the misfortunes of genetics and the environment. Eventually, a good number of folk are going to develop something one way or another, and it's that identification and a desire to learn more about what the future holds for individuals at a point when something might be done that has driven the project that brought us together, Fiona.
Yes.
So tell us about the project that we're doing together.
So we work on a project called SCOON, which is the Scottish Collaborative Optometry Ophthalmology Network e-Research. That's why it has an acronym, because we can't say that all the time. So essentially, we are harnessing the power of the retinal images that are captured by optometrists in Scotland every day in their practices, and using that to find out more about the links between the eyes and the general health, find out more about how we can detect eye disease at an earlier stage, and how we can predict the progression of disease once it has been diagnosed.
That's a very good summary. And in terms of what the nuts and bolts of that looks like, it's a retrieval process, having gone through a number of really stringent rules and regulations and ethical approvals and code.
Absolutely. So the governance surrounding a project of this nature is always going to be extremely strict. As you mentioned, we've taken advice from the Caldecott Guardians. We have co-sponsorship from NHS Lothian and from the University of Edinburgh, and all the safeguards that brings. And we're operating within NHS Scotland's National Safe Haven, Public Health Scotland's National Safe Haven, which means that there's very sort of strict security measures and governance requirements, ethics requirements to do work of this nature. Essentially, we are retrieving retinal images from community optometry practices. They have been captured in some practices for 10, 15, even 20 years in some places. Obviously, it's impossible to go around and ask every individual patient, can we put your photo in this national safe haven? And so going through this kind of strict governance and things like the Public Benefit Privacy Panel approval, which we received in October 2021, means that the benefits to the public from the project are so high, the potential benefits, that as long as we have these very strict, stringent safeguards in place, we're allowed to do pseudonymised research on these images, meaning that there's no personal identifiers available.
And so we brought together a number of individuals, present company accepted, who are going to be able to scrutinise that data using AI and deep learning. And so being a zillennial, you'll be familiar with these terms and coding and digital information and health informatics, or is this all new? Did you learn the basics at Glasgow Caledonian University, or are you picking it up on the job?
So I definitely knew some things about AI previously, but mostly just kind of what's in the news. Once you start looking into AI, you realise that it's kind of already everywhere. It's in agriculture, it's in factories, it's in many healthcare professions already. Almost everything you do on your smartphone has some form of deep learning algorithm within it. And so, but really how AI works, how it learns is something that I learned more about after I joined Scone, certainly, because I think it's really important if we are, hopefully creating these tools to help optometrists and eye care professionals with their clinical management of patients, that it's not a kind of black box that just gives them out an answer. We can actually explain to the practitioners, how do we get to this point? How does this actually work? Because then they're going to have a lot more trust in the results and the information that they're being given from these tools.
Yeah, and in that sense, if we could turn the clock back, maybe would have written our curricula at school differently, or our university learning differently. But certainly this is going to be transformative in terms of how we can enable our diagnostic capability through AI tools to recognise and crystal ball gaze to predict different outlooks for individuals, whether they're healthy or they have one or more comorbidities. And I think that'll change how we practice, do you not think?
Definitely. I mean, you think how much the technology we have now has changed, practice in the last 20 years or so. We went from being able to look at the retina with a direct ophthalmoscope and having that very limited sort of two-dimensional field of view to now we have, colour fundus photography, we have OCT, we have ultra-wide field imaging, and these are available in the high street. So it's, you can, many community practices, all of them will have certainly a fundus camera, a retinal camera, but many will have OCT and ultra-wide field imaging as well. And we've really only scratched the surface of what these images can tell us. The information about, yes, diagnosis of eye disease and managing patients that way, but also the associations with the general health. And increasingly, optometrists, we're understanding the role we have in primary care, not only just for the eyes, but also as kind of the canary in the coal mine for some other, health conditions, whether it be diabetes or hypertension or even neurodegeneration.
Yeah, so it's going to enable a whole new Pandora's box in some ways of likely diagnoses, which, whether you're healthy or whether you've entered a phase where you're getting one or more conditions, you're going to be able to take a look at what might be the case if we continue the lifestyle that we're continuing, and we take active measures, I'd guess, to try and prevent the awful or the more awful scenarios and veer towards the better scenarios. I think that would be enabling. I mean, what's your take on how that can be delivered in the high street in terms of advice on behaviour, for example?
So certainly with things like AMD, particularly dry macular degeneration at the moment, it is very much lifestyle advice based information that we're giving, and often it is difficult for a patient to quantify their own risk, the risk of progression or, the risk of sight loss. It's kind of an abstract thing, and people don't really like to think that bad things will happen to them, so they probably downplay their own risk profile. I certainly do it with other health conditions. This is not something, it's something that everyone does. Yeah. And so being able to quantify that risk and really give tailored advice to our patients is going to be incredibly useful. But as you know, all AI tools, they're only ever as good as the data that they're trained on, and that's why SCOON is so important, because it's primary care data, it's images captured in community optometry practice. So any outputs we have from the research and any tools that come from it are going to be highly relevant to that setting, because it's a true reflection of the population that we see.
Absolutely. And it, in a way, it democratizes the data that's being derived from individuals and feeding it back to individuals, so they recognize the state of play and are offered advice, guidance, sometimes treatment, and what to do about it. So it's a very exciting prospect. And I guess it feeds back to your master's project in a way, because in order to have a representative view, we need urban, rural, wide uptake, and the landscape in terms of optometry, in terms of accessibility, I guess is a bit variable, particularly in rural locations and certain parts of Scotland.
So with optometry in Scotland since 2006, it has been NHS funded, meaning that everyone who lives in Scotland can get a free eye examination. This is very different from the rest of the UK, where some risk profiles such as age or family history or diabetes will allow you to have a free eye examination, but the vast majority of people pay for them. And the removal of that cost barrier has improved the accessibility of eye care services for certain sectors of the population. The spread of practices across areas of deprivation is actually fairly equal in Scotland, although there's still some work to do on the uptake of eye exams between different groups. But certainly urban, rural, it's as with all healthcare specialties, rural is underserved in terms of number of practitioners, and without the backup of the specialist care services that we have in the urban areas, a lot of time the practitioners in these areas are working very, very hard, going sort of above and beyond for their patients, because often they are the only ones there to deal with it. And so there's certainly a lot of work has been done to improve that equity of access to eye care in Scotland, but there's still further work which could be done to improve it even further and make sure that we have actually universal eye care. Yeah,
I think it's laudable that Scotland did implement that, and I agree. The unsung heroes in rural practices who are working far beyond any contracted hours, whether independents or chains, do require and deserve a big thumbs up. So we're nearing the end of our time. Paul is waving his hands madly at me. I just want to finish by saying what a delight and a pleasure it has been chatting to you about a number of things. I know that you do actually enjoy a very healthy lifestyle. You ride a bike, you surf, and I dare say you occasionally do other things. What gets you out of bed in the morning? As a final question.
My 15-year-old dog wakes me up at 6 o'clock every morning.
Excellent. So long,
a very regular alarm clock on that one.
Long may that continue. Anyway, Fiona, thanks very much. It's been great talking to you.
Thanks for having me.
Pleasure.